Our first topic is sepsis, and that will be delivered by Dr. Becky Barron. Becky is one of our ICU MICU attendings. She's also really the head of the research program in the medical ICU and the director of the medical ICU registry. She'll be speaking on sepsis. Thanks very much, Becky.
Thank you, Jerry. Thank you to the course organizers, and thank you to all who are tuning in remotely. It's really a privilege to be part of this in this unusual era. I apologize in advance. You never start a talk with an apology, but I just did because I'm going to zoom pretty quickly because there's a lot of content to cover here, but everything is in the slides if you want to go back and look later. My conflicts are listed here. I'm going to start with a quick case. This is a 47-year-old woman with alcoholic cirrhosis brought to the emergency department with fevers, confusion, shortness of breath, and worsening ascites. Temperature is 37 degrees, systolic blood pressure of 50, heart rate of 150, respiratory rate of 40, central venous pressure of 4, 90% saturated on room air. A chest x-ray has diffuse infiltrates, and a peritoneal fluid returns with a leukocyte count of 1,000 per microliter, 95% polys, consistent with peritonitis. Question number 1 is, does this patient have sepsis, and by what criteria? Before we even get to that, I had to at least insert the notion that now any patient arriving to our ICU immediately is ruled out for COVID, which has unfortunately become a very prevalent cause of a sepsis-like syndrome. And I won't focus the talk on this, but these are the times we're in. And as many of you know, COVID is believed to bind to the human ACE2 receptor on the lung epithelial cell and initiates a pro-inflammatory downstream cascade, which results in a sepsis-like state. But getting back to the sepsis definition, many of you may recall that for 15 years or so, we used this rubric. SIRS, or the Systemic Inflammatory Response Syndrome, characterized by 2 out of 4 of these criteria. Sepsis was defined as SIRS plus suspected or documented infection. Septic shock, defined by sepsis plus refractory hypotension. And then there was this intermediate category that's largely been abandoned. And I just mention this because many of us and many emergency departments and other screening metrics still use SIRS. However, many of you will also know that in 2016, the latest consensus conference came out with Sepsis 3, which is the current consensus conference definition of sepsis, which is defined by life-threatening organ dysfunction caused by a dysregulated response to infection, defined by an increase in the SOFA score, which I'll show you on the next slide, of greater than or equal to 2. So if a patient has organ dysfunction at baseline, the definition requires an increase of 2 points. And using this definition, sepsis was defined by the consensus conference of having at least a 10% mortality. Septic shock, defined as vasopressors with requiring vasopressors for mean arterial pressure, maintenance of at least 65, a lactate higher than 2, and without a response to volume challenge. This is the sequential organ failure assessment score, or the SOFA score. And again, the hallmark of this consensus conference's definition was that sepsis wasn't just the presence of an infection, but that organ dysfunction is indicated by respiratory, hematologic, GI, hemodynamic, neurologic, or renal dysfunction, with a range of points shown here was required to define organ dysfunction. Many of you may also know that they came up with this quick SOFA, Q-SOFA score. This was never designed initially as a screening tool. It was designed to characterize those patients who were predicted to have worse outcomes, who were out of the hospital in the ED or in ward settings. And it was defined as 2 out of 3, an elevated respiratory rate, altered mental status as defined by the Glasgow Coma score here, or hypotension as defined by the systolic blood pressure. There are many studies that have been published and are still ongoing looking into its validation. And if it's used as a screening tool, again, it was really designed as a prognostication tool, but if it's used as a screening tool, the concern is that it's less sensitive, but more specific than SIRS for sepsis screening. And the most important thing, of course, is that we don't want to miss cases of sepsis. So many people are still using SIRS for sepsis screening. For those of you who follow this field, there have been many critiques of these definitions, some of which include those listed here, that lab testing is required, so it may not be relevant to resource-limited settings. Biologic markers were not included in this predictive model and this tool, and many people thought this was more of a billing tool rather than a definition tool. But there are many current studies ongoing, looking at these criteria and others shown as an example here, trying to harness artificial intelligence, big data, to really better determine with all of the range of information that we now have about our patients from electronic medical records, whether we can better define sepsis. So stay tuned, there'll be more in this area. So how do we currently summarize what we think currently? So SIRS may still be the best screening tool for infection. Again, it's not as specific as some other tools, but is more sensitive, so you don't want to miss infection. Screening for organ dysfunction and using the SOFA to define sepsis, and then the Q-SOFA for prognostication. And then septic shock is usually more readily discernible refractory hypotension with an elevated lactate. So the bottom line is you don't want to miss sepsis. You can screen with SIRS, prognosticate with the Q-SOFA, and diagnosis of sepsis with the SOFA score. So the same patient, question number 2, has alcoholic cirrhosis. Remember, the TAP was consistent with peritonitis. The chest x-ray shows diffuse infiltrates. You initiate your sepsis bundle. Initial management should entail use of which of these? Vasopressin, norepinephrine, norepinephrine plus furosemide, intravenous fluids, or dopamine. Great, I'm gonna move on. It looks like the majority of people said intravenous fluids, but there was a range of answers. There we go. And I was going for intravenous fluids, and I'll explain why here. You would think it's a fairly straightforward answer, and that is the initial response that I intended, but I'm going to talk a little bit more about current approaches to fluids in sepsis. So irrespective of fluid and pressures management, source control is still the hallmark of sepsis. If we cannot target the initial infection, we certainly will not be successful, irrespective of the other management. So this is the time for early, broad, empiric antibiotic therapy. It's not the time to be elegant. If there's data that every hour of missed appropriate antibiotics increases mortality in a linear fashion. So this is of critical importance. And if there are sources that are within the patient that can be drained or removed, they should be removed. Source control is really critical for elimination of the infection. Once you know the pathogen, then antibiotics can be appropriately tailored. And as many of you know, in terms of what we hope would be the equivalent for source controls and antiviral in COVID, and at this point in time, the latest data suggested that remdesivir shortened time to recovery in the less sick patients with COVID. So for 13 years or so, many of us pursued this strategy of fluid resuscitation, early goal-directed therapy that was published by the group from Henry Ford. And what they did in terms of the early goal-directed therapy was they began a fluid resuscitation strategy in the emergency department as follows. So the patient was admitted. They received crystalloid, 500 cc's of fluid every 30 minutes, targeted to a central venous pressure using a central line. And at the time when the study was started, this was quite a bit of fluid for a medical patient. There was reluctance to really bolus medical patients aggressively for concern that you might precipitate heart failure. They then used norepinephrine to target the mean arterial pressure. And then they had some other interventions here. They used a central venous saturation monitor and gave red cell transfusions and or inotropic agents to optimize the central venous saturation. And then if the patient improved, they were admitted. And if not, they continued on this pathway. And what was interesting about this study is you can see here that the patients in the first 6 hours who were on early goal-directed therapy received significantly more fluids than the standard therapy group, though both groups got a lot of fluid, 13 liters, by the conclusion of the protocol. And many people believe this was the critical finding in this study, that early targeted fluid management was what was really important. There was also more red cell transfusion, and as many of you know, this has been largely abandoned. There was also more inotropic use, and this has also been largely abandoned in this protocolized manner. And there was similar pressors use. And there was a mortality benefit in this study. And in 2001, this was huge. This is one of the first and only studies at that time that showed any mortality benefit in sepsis. And ever since that time, there's been a lot of questions into this bundled approach as to what are the key components and broader applicability of what worked. In 2014, there were 3 trials that came out, one from the US, and this is the example I'm showing here, the process trial, one from the UK and one from Australia, New Zealand, and they showed similar findings. They had similar strategies. They compared early goal-directed therapy versus early goal-directed therapy light, protocolized care without the central line, inotropes, blood, et cetera. So basically the top part of the protocol, just using fluids and pressor support versus usual care. And there was no difference in the primary outcome of 60-day in-hospital mortality or other outcomes. So in contrast to early goal-directed therapy, this and the other 2 studies did not show any mortality benefit of early goal-directed therapy. And why might that be? Well, the overall mortality was substantially lower in later trials, and suggesting, and other studies have supported, that usual care has evolved and improved sepsis management, in large part because of earlier and more aggressive initial fluid administration. The patient population was a little bit different. And this trial in general practice supports that early antibiotics and fluids are probably what was most important in that study. And people have largely abandoned the need for central lines in everybody, red blood cells and dobutamine early on in the protocol. And targeted fluid resuscitation is now the goal. If anything, people have now worried that the pendulum may have shifted too far in giving excess fluid. The data suggests that too much fluid is probably not beneficial in sepsis. Too little fluid, we know prior to early goal-directed therapy, was not beneficial. And how do we target it appropriately? And that's really the million-dollar question these days. This is the current surviving sepsis guidelines, and you can look in more detail at your leisure if you want to. But what is recommended is an initial fluid bolus, and it may be modified based on the oxygenation or dialysis state of the patient. And then after the initial infusion, to use a metric to guide fluid resuscitation. And the fact that they give you a menu here suggests that there's no one that is proven to really be all that superior. Blood pressure, heart rate response, urine output. Obviously, some patients can have acute kidney injury and not have urine output as a reliable metric. Use of ultrasound, use of the central venous pressure and central SATs as were done in early goal-directed therapy, pulse pressure variation, et cetera. And I will say in our practice, my colleagues, each of us has preferred methods. And I think what this comes down to is you can't really fully protocolize sepsis. There needs to be bedside assessment of targeted fluid resuscitation. I personally like looking at combinations of central venous pressure, central venous sat responses to fluid challenge or a straight leg raise, which is essentially an endogenous volume challenge, and trying to figure out where someone might be on their Starling curve. And so this happens to be a picture of a Starling curve, but I draw your attention to this JAMA 2016 article, which goes through all of these various different metrics, the data behind them, and how useful they are, if you're interested in this. And it is a very nice review of how to think about titrating fluid resuscitation and monitoring fluid responsiveness in hypotensive septic patients. This topic is so unresolved that it's the subject of an ongoing pedal network study, the CLOVERS trial, which is randomizing patients in emergency departments currently targeting either preferential use of pressors after initial volume challenge or preferential use of fluids after the initial volume challenge. Again, getting at this issue of, are we currently giving too much in the way of fluids? Is there a happier medium between pressure support with fluids or pressors? And we're hopeful that we will have an interesting answer to this question. What sort of fluid should we be using? Many of you know that for many years, normal saline was the choice of fluid resuscitation in the ICU. These two studies here in 2018, the one on this part of the screen, the critically ill patients, is the one that has guided a major shift for many of us to favor lactated ringers over saline. There had long been speculation that the chloride load of saline might be nephrotoxic, and this study suggested that might be the case. And there's still other larger randomized trials. This was a single center trial. There are other trials ongoing currently, but many of us have now moved toward lactated ringers as the fluid resuscitation of choice. So bottom line in sepsis with regard to fluids, bolus crystalloid, don't overdo it, find the targeted resuscitative strategy, and whatever that is, use your bedside judgment for fluid resuscitation. So now back to our patient with spontaneous bacterial peritonitis. You give her fluid resuscitation with 3 liters of crystalloid. Her heart rate comes down to 100. Her systolic blood pressures come up to 65 with a mean arterial pressure of 50, and the CVP is 13. You next order vasopressin, norepinephrine, and furosemide, 1 unit of red cells, or dobutamine. And I'll just give you a few minutes for this because of time. Great. I saw a lot of norepinephrine, and I saw a range of other answers. And as I'll show you, there's always no obvious firm right answer, but what I was looking for was norepinephrine, and I'll explain the rationale. So the question is, what's up with pressors? Get it? The joke of what's up with pressors, the blood pressure. Anyway, you can't do jokes on Zoom. But here's just a quick review of the actions of vasoactive catecholamines. Many of you know that phenylephrine is the primary alpha vasoconstrictor versus beta, where agents like dobutamine that have contractility support are in that range. And agents such as norepinephrine have a mixture of alpha and beta, as well as epinephrine. And based on data from 2010, norepinephrine has really emerged as the pressor of choice. It was compared in a study of patients with shock to dopamine, which previously was more favored, but not surprisingly to many of us, dopamine was associated with more tachyarrhythmias. And so norepinephrine has really emerged as the pressor of choice, and epinephrine, based on one study, has emerged as the second pressor of choice. Some of you chose vasopressin, and if you're like our ICU, we use a lot of vasopressin as well as a rescue, and it's based largely on this study, the VAST study, where there was no significant mortality benefit in adding vasopressin to norepinephrine, but the less sick people seem to do better with the addition of vasopressin. And so it's many centers, such as ours, use vasopressin to spare higher doses of norepinephrine and potential toxicity from excess alpha and vasoconstriction and tachycardic effects that might come about from other pressors use. I will just mention quickly that in 2017, a novel class of vasopressors, angiotensin, came out. It was an add-on study where it more effectively increased the mean arterial pressure when added on to conventional vasopressors. And I just mentioned it because as I had told you, coronavirus binds to the ACE2 receptor. So people are thinking about angiotensin, whether it may have a therapeutic role in COVID, and there's no data that we're aware of for now. But there is another study ongoing currently in sepsis looking at angiotensin too. So this is the current surviving sepsis guidelines for pressors use. If norepinephrine alone or addition of vasopressin is not successful, then epinephrine would be the next pressor of choice. And then you're really sort of on your own. Some people might consider addition of phenylephrine. Again, phenylephrine has pure alpha effects. So the last major area I want to talk about is, of course, the most complicated, but I will summarize it to tell you we still don't really know what to do with steroids and sepsis, but I'll go through very quickly. So for a number of years, we thought of this concept of relative adrenal insufficiency, that patients who were sick did not have absolute adrenal insufficiency necessarily. Patients with absolute adrenal insufficiency or on chronic steroids definitely need steroid support during critical illness. But some patients, it was thought, may not have adequate adrenal reserve to get through a stress. There have been studies that high-dose corticosteroids did not improve sepsis outcomes, but for a period of time, there were studies that suggested that a subgroup of patients, depending upon their response or lack thereof to a CORT stim test, might benefit from low-dose steroids. And so for a number of years, we did this. We did CORT stim tests. We looked for those who might benefit from low-dose steroids, and we gave short courses of low-dose steroids with a total of 200 milligrams of hydrocortisone over a 24-hour period. And then in 2018, so just 2 years ago, 2 large trials were published. One of them did not show a mortality benefit at 90 days. Another one that included sicker patients did show a mortality benefit. And I think that this summary is really the current bottom line. It is unlikely in the near future that we will have sufficiently powered trials with better data. Clinicians will have to use these data and subsequent meta-analyses to decide how best to treat patients with septic shock. Estimating 90-day mortality at the bedside is not practical. It's likely that some practitioners caring for a patient with a deteriorating condition who is receiving escalating doses of pressors and whom other core interventions have been instituted, like antibiotics, volume resuscitation, source control, like we talked about, will consider that the short-term benefits of low-dose hydrocortisone may exceed any risks as an added therapy. Many of you may see also that dexamethasone for COVID in the sicker patients was supported by the recovery trial, by one study, just as an aside. So this is the current guidance by the Surviving Sepsis Campaign for steroid administration. It's no longer advised to use a CORT stim test. It's based on decision-making at the bedside. So once a patient is on norepinephrine and requiring vasopressin, you can see this asterisk here. It says consider IV steroid administration. If a patient then requires epinephrine, it says administer IV steroids. And I will say many of us will empirically give steroids according to this fashion when someone has refractory hypotension. I think it depends on the scenario. From my own personal perspective, I think someone is really floridly septic and we haven't achieved source control, I might pause a little bit. But this is the current guideline for steroid administration. I'll just point out that there have been a couple of vitamin C studies, and it was got a lot of attention a number of years ago with an earlier trial. Both of these studies were negative for the primary endpoint, and there are more studies coming. No clear benefit yet for vitamin C. There are some adjunctive sepsis care aspects that you'll hear about in other sessions. We no longer do tight glucose control, but we target a glucose of less than or equal to 180 rather than tighter control. Low tidal volume ventilation, and you'll hear more about that. We talked about fluid management, and in acute lung injury, the studies suggest that dry lungs are happy lungs once patients are hemodynamically stable. Again, this notion of not aggressively fluid overloading patients if we can hemodynamically support them. Protocolized central line insertion and attention to ICU bundles and prophylactic care. And then just to summarize, early identification of patients with sepsis, and note the new guidelines, source control, early broad spectrum antibiotics, early fluid resuscitation, primarily with crystalloid. And I put early goal-directed therapy in quotes, meaning targeted fluids. Norepinephrine is the first pressor of choice. Consider addition of vasopressin to norepinephrine. Consider epinephrine as the second-line agent for refractory hypotension. Limited role for dopamine and neosynephrine as initial agents of choice, and angiotensin is a new agent. Activated protein C, I didn't talk about, is no longer available for those of you who remember it. Consider low-dose hydrocortisone for patients with refractory hypotension, perhaps in the sicker patients. That may be where the benefit is higher. Uncertain of how tight glucose control should be, but the target is now less than or equal to 180, and it's critically important to avoid hypoglycemia. And then attention to standard care is probably as important as anything, taking lines out when we don't need them, prophylaxis, et cetera. And just to summarize this way, patient comes to the ICU, antibiotics, source control, fluid challenge. If they remain hypotensive, early goal-directed therapy in quotes, meaning targeted fluids. If they're getting better, that's great. If they're not, this may be a group where if they have refractory hypotension, you might consider low-dose hydrocortisone. If they're getting better, that's great, and narrow antibiotics according to cultures. If they're not getting better, we're really in a data-free zone. It's important to make sure that we have the right diagnosis. Did we miss a source? Is there not effective source control? There's really no data for steroids at this point in time. And unfortunately, is this someone who may not get better? Is this a time to start thinking about the direction of care? Here are some selected references, and thank you very much.
Thank you so much, Becky. That was wonderful. There are a couple of questions in the chat, and we have a couple of minutes, so maybe we can take them. Some of them have to do with lactate, so let me see if I can summarize a little bit. One of them asks, what do you recommend for patients with signs of an infection and an elevated lactate, but without hypotension? Is that somebody you would consider to have sepsis? And I'm going to ask a corollary question to that because it was asked by another participant, which is, would you still give lactated ringers for somebody with a lactic acidosis?
Sure, those are great questions. So signs of infection, regardless, I would treat as sepsis. And I would worry if someone comes in with signs of infection and an elevated lactate that there was organ hypoperfusion. That gets into the question of whether they have septic shock or not. So if they are not hypotensive, they may not qualify as septic shock, but I would worry about organ hypoperfusion in the setting of suspicion of infection. And many of you may remember that lactate screening was implemented widely as part of the Surviving Sepsis campaign initially. So I would definitely pay attention to that. With regard to the question about lactated ringers, yes, in general, if someone has normal liver function or doesn't have high tumor burden and production of lactate, we should still be able to clear lactate. So in general, we still are giving lactated ringers to those patients with hypotension, septic shock, and an elevated lactate. In some scenarios where there's significant liver disease or tumor, it may then be hard to monitor.
Great, thank you. And a couple of participants were asking about why IV fluids and maybe which IV fluids you would give for people with ascites.
Yeah, that's a really difficult question. I didn't have time to mention, but it does say on the surviving sepsis guidelines that you can use albumin in scenarios where you do not want excess amount of third space fluid. So the patients with ascites who are hypertensive are definitely challenging. And in those patients in particular, if someone, we didn't get into this with this case, but if someone had bacterial peritonitis, they might qualify for albumin as part of that therapy. And in those patients, I might opt for limited or judicious crystalloid, and then think about more in the realm of colloid, again, because of the third spacing for those patients.
And maybe just a final question, although there are many very good ones, and maybe we can get to them later on. Any thoughts on high-dose vitamin C infections for infusions, for septic shock? Any benefits, any harms?
Yeah, so it's a great question. It's still being studied, and the PEDAL network is trying to propose another study. There's no data yet. There was one study that suggested maybe some benefit in terms of organ dysfunction, but to date, there's really no supportive data for vitamin C at this time. As much as many of us pray and hope that we will have a panacea like that, it can't. We still don't have evidence to support it yet.
All right. Well, thanks so much, Becky. I really appreciate it.
Great. Thank you.